Hello.
Hi, Ivy. How are you?
Hi, good. Is my audio working?
Yes.
Okay, perfect. I had like so many microphone choices. I wasn't sure which one was the right one.
Now I can hear you clearly.
Okay, great. Hi, Lisa.
Yeah, Abby.
How are you?
Good. How are you?
Good. It's been a while.
No.
Yeah. I was like, oh, I get to see everybody. I haven't seen in a long time.
Yeah.
You guys can see my presentation screen, right?
hmm
Slides. Okay, perfect.
Hi, Abby.
Hi, Anita. How are you?
Good. How are you doing?
Good. Just
Thank you so
taking
much.
a little break from clinic. So
Yay. Well, thank you for fitting this in. It's awesome.
yeah, I took your theme, your guide, your
Yeah,
topic, and I just kind of went with it. So
perfect. No, it's perfect.
yeah,
We will
it's like,
all learn a lot.
okay.
So, yeah,
It's just like, what would I want to know if I was a fellow and needed to decide where to practice?
perfect. No, I think that's awesome. And I think it's
All right.
helpful for all of us as we try to be, helpful mentors, like finger on the pulse in terms of
Yeah.
how to
All
guide
right.
people in that decision too. So I think it's good for all of us to learn
Cool.
your
Okay.
perspective as well.
Yeah.
So awesome. We'll just give it another moment as people are logging on and then we'll
Okay.
get started.
Sounds good. Yeah. Just let me know.
Okay, perfect. All right, I think we'll go ahead and get started. So hi, everybody. Welcome to our grand rounds today. I'm excited to introduce Dr. Abby Dunn. She did her undergrad here at Michigan, did her medical school in Toledo, Ohio, and then did neurology residency and sleep medicine fellowship training with us here at Michigan, and then stayed on our faculty for a good number of years before going back home to Toledo, which is where she's practicing now. So I had asked Dr. Dunn if she could share with us her insight on practicing in these different practice settings now that she's kind of had experience in all these types of different practice settings, both for our fellows and for us as faculty, as we're guiding fellows in helping navigate the job market and potential choices. So, Abby, so excited you're here, and I'll turn it over to you.
Thanks, Anita. So yeah, when Anita gave me this topic, I was kind of like, okay, well, there's not much, evidence base for this. I'm not going to be doing a lot of research, but like Anita said, I did work at U of M as an attending for 5 years after my training, and then ultimately decided to move back to Ohio, where I work in I guess as a physician group, community-based practice currently. And so, kind of drawing on those experiences here for our talk. I know you guys are about a quarter of the way or so through your fellowship. So, you kind of have to think about where do I want to go from here? My fellowship's almost over. I have to start looking for a job and figuring out what do I want to do with my life and my first job as an attending for probably the majority of the fellows. Um, so I remember being in your shoes years ago. So hopefully this is helpful to have you help you pick a direction of which to go. So there's some big categories of practices out there. This kind of goes for all specialties, but you're looking at your academic practice, your kind of employed community practices, whether it's in a physician group or you're employed by a hospital system, or looking at a private practice. So when you're, deciding what to do, those are going to be your three big buckets. There's different types of practices within that. So, you're looking at your solo practitioner, whether again that's hired by a hospital or a physician group, or if that's a private practice that you'd be starting yourself. You can be in a multi-specialty group, which is kind of how things are run, I think at U of M, where you have physicians from different backgrounds all working together in the sleep clinic. But also, there's other ways that that could be set up too. So, for example, the practice I'm in now is actually a pulmonary and sleep practice. My training was in neurology, so I'm the only neurologist that works for our group. But I do only sleep medicine at this point. So it's me, a bunch of pulmonologists, and then we have a couple other sleep practitioners as well who are from internal medicine backgrounds who don't do pulmonary. You can join an independent practice, just a private practice that's out there, perhaps maybe, that's been started by another physician, or you can have affiliations with sleep labs that are out there. We'll go through all of these differences. So your starting point, again, looking at these big buckets and then deciding, okay, am I going to be joining a practice that's established? Am I going to be starting my own practice? Am I going to be inheriting a practice of, say, somebody that's retired? Those are things that you need to look at as well. So the big things that you need to consider when you're looking for a job is, do you enjoy teaching? Is that something you want to do? So you're all in the fellowship now, so you're exposed to teaching. That's what the environment you've been in for years in residency and medical school. You need to look at, do you want to do research? Is that something you've been exposed to or interested in? Do you have any interest in administrative roles, things like, program director or directing, say, a sleep clinic or a lab? What are you looking for in terms of schedule? Do you need something that you're in control of that's very flexible? Does that matter to you? And then again, hybrid specialty practice. Are you certified in another field of medicine? Are you, looking to do internal medicine, see patients for neurology, pulmonary? It just depends on your training, but is that something you want to do in conjunction? Certainly location is a big factor, I think, for all of us, if we want to live where we want to live. So location may definitely play a role in what's available where you're trying to go. If you want to do telemedicine or not, I think during the pandemic, that's when telemedicine exploded. Probably almost none of us were doing telemedicine before the pandemic, and then we pivoted to doing almost all telemedicine in that point for a few years. But now, we're kind of to a point of deciding how much telemedicine, do we do in a practice, especially with some of the things that are going on with our government, Medicare, are they going to be covering telemedicine going forward or not? That's another big factor to consider. And then how your practice is structured. Are you going to have advanced practice providers, APPs, your NPs, or PAs? So those are all things to kind of think about as you move forward. If you're going into academics, you really should have some kind of, special interest, some kind of practice that you really want to focus on and kind of make your kind of subspecialty, I guess you could say. If you want to do research, you need to think about, okay, if I want to do this research, how am I going to get paid to do that? Or how am I going to get funding to do that, since the money doesn't come from nowhere, whether that's going to be grants or industry sponsored. That's a big factor in being able to actually go out and do the research that you want to do. You have to think about, okay, well, I'm in this academic practice. What kind of academic work am I putting forth? So things like writing papers, writing book chapters, doing presentations, grand rounds, that's all something that you need to, put forth to continue your academic practice. Teaching certainly is a big part of that, whether, it's med students or residents or fellows. Teaching is a big part of academics. It's kind of probably the whole start of academics, where that came from. And then certainly your clinical role, seeing the patients. We got to see our patients, move the patients through. How's that going to work with everything else that you need to get done in your academic practice? In community practice, it's where I am now. It's mostly clinical based. So I would say 99% of my time now is when I'm here, I'm in clinic, I'm seeing patients, or I'm reading sleep studies. Um, it depends how sleep labs are set up affiliated with your practice, whether you're affiliated with your own sleep lab or if you're applying to get privileges to read studies that are performed at other centers or other hospitals. So for example, in our practice, we have 7 sleep labs at different locations. All of us are a medical director for one of those labs. But if I wanted to go get privileges at a different hospital, a different system, I could apply for that and I could read studies, done at different places. I haven't done that. But that's something that can be done depending on how your practice is set up. In community employed practice, again, academics as well, you can have APPs, have to decide kind of how you want that to play out within your practice, how you're going to use an APP to help you, essentially. So in our practice, we do have nurse practitioners. The way that we have set this up is we have trained our own nurse practitioner to be part of our practice. And what we have found works the best for us is having the physician see the new patient, and then having our APPs see those kind of stable return visits to take those kind of off of our plate to move in more new patients to be seen. Certainly with a lot of supervision, if there's issues, problems, certainly we are all, more than willing to take those patients back on, see them in our clinics, but you have to kind of think about how APPs are being used in the practice that you're going to be going into. And then is there a role of having fellows or having residents or med students come into your practice? So our practice, while it's not an academic practice, we do have affiliations with the University of Toledo, and they have med students and residents that come through. Today I had a neurology resident in clinic with me. Our program at ProMedica, they have some residencies. I think they have a family practice now. Sometimes we'll have those residents come through. So not as frequent or big of a part as say in an academic practice, but probably if you want that exposure, you can figure out a way to make that work. And then in community practice or in employee practice, we have a position group, that's who's hired us, and there are administrative roles based in that group as well if you wanted to take on a role within a hospital or sleep lab director. If you're going into private practice, we kind of call that eat what you kill, right? So you need to see the patients, you need to do the billing to get paid. So what you're seeing, what you're doing, that's how you're making your money. Just have to remember that you're basically wearing all the hats if you're starting your own private practice, and that's the business side. So I think you really need to be comfortable in that business management side of things, which I personally am not, so I'm not pursuing that. But I do think the benefits of private practice are flexibility in some cases not, right? Because you're the boss, you're the one that's always needing to be there, especially if you are the one running the practice. You can certainly be employed by another physician in a private practice, but if you're starting your own or you're the one that's controlling the business, is that more flexible or is that less flexible? I guess that's a personal opinion. In private practice, you need to think about, okay, what's my referral base? Where am I going to get patients from? If you're not within a health system, you don't really have a built-in referral base. So in academics, certainly you guys see referrals from a variety of specialties, right? They're just coming in all the time. Same in community practice. We have, physicians, we have internal medicine, family practice, cardiology, everyone sending us referrals. It's just built into the system. But in private practice, you're going to have to sort out and kind of get out into the community to meet other physicians who are going to refer their patients to you. And then you're going to have to figure out, okay, am I going to open my own sleep lab, which again, there's a learning curve there as, setting up a lab from scratch. versus am I going to go out and just get privileges at various hospitals in the area, send my patients there, read those studies, get them back, or, if you don't have privileges, your patients would be getting studies done elsewhere, and then you're just relying on those interpretations coming back to you. You also have to think about, okay, if I'm going on a leave, if I'm having a baby, if I'm going on vacation, who's going to cover my practice? Whether that's locums or you're covering yourself. But I think in terms of a work-life balance, that's also a big thing to consider, regardless of what practice you're in, is how does that work if I need to be away or on an extended leave. I also have worked in some rural settings. So as part of ProMedica, we have various outreach clinics, satellite clinics that are in some quite rural areas. So I go out to Fremont, Ohio, which is probably halfway between Toledo and Cleveland. And then I also, when it was part of our system, was going out to Coldwater, Michigan once a month, which is out by Hillsdale, if anyone's familiar there. But these are, quite rural communities. I do think there are some differences when you're working in a rural practice in terms of access to care. You're probably going to be the only specialist around for quite a while. In the case that I was working in Coldwater, they had a sleep medicine and pulmonary physician in town who retired. They were left with no sleep medicine provider in town, in the city. And we were inundated with referrals to see patients. Some of the things that will come up if you're in a rural practice is, okay, where do I send these patients if I need to send them to a dentist for, say, mandibular advancing oral appliance? What if they have hypoventilation? I need to send them, to a pulmonologist, or they need to have surgery for sleep apnea or obesity management. You're going to have to think about, how am I going to get these patients the care they need? A lot of patients in rural settings, don't necessarily want to travel, which can make things difficult. And many of these things are difficult to do over telemedicine. I think one thing that you guys are really fortunate to have there is your insomnia clinic with lots of access to sleep psychologists, which I think is very rare out here in community practice in Toledo. We had one sleep psychologist in town who was affiliated with the university, and she has since retired. So we don't have any sleep psychologist in town. There's a nurse practitioner at one of the other groups in town who did go through CBTI training, although she's not a psychologist. But that's really the only person in the area who's able to assist with these insomnia patients for formal CBTI. So we do rely on telehealth in those cases too. So referring people for virtual CBTI consultation. Downside is, it's hard to do some of this stuff over telehealth. Patients in rural areas have poor internet connections. Some patients are older. They might not have internet. They might not have a smartphone. They may not just have the technology to be able to do these visits. And then you may run into some special populations, like I saw Amish patients, which I was not seeing in practice, but that has some individual aspects to it with not using electricity, right? So CPAP, trying to use things like they're trying to use generators, getting them oral appliances. So there are some special considerations with patients in rural practice for sure. When you're looking at choosing a job, there's a lot to consider. So when I was looking for a job, when I was a fellow, I don't think I really knew all of this information. It wasn't something that was on my plate. But you want to know, okay, how am I going to be paid? Who's paying me? Am I employed by the hospital? Am I employed by a physician group? Exactly who is employing me? You want to know what the terms are to that contract, obviously. How many years is this going to be? Do I have a non-compete, meaning are there restrictions on me if I were to leave this job, or I wanted to start my own practice? What's the non-compete? Is it that I can't practice within 20 miles for a year, 2 years? You need to figure that out for your future. You really should know what's the expectation in terms of how long am I going to be expected to be in clinic each day? What does that look like? Is that a certain amount of clinical hours? Do sleep studies, apply to that? Is that within my clinical hours, or is this just clinic time? In terms of your compensation, you want to make sure it's fair, first of all. So you might want to get access to the MGMA data that kind of gives an outline, although again, that may not be exact just because, it's probably a limited pool we're getting that data from. But you need to look out for things like, is there a signing bonus? Some employers will give you a stipend while you're still in fellowship. If you sign early, you need to ask these things. Is there a 401k match? I knew nothing about investing. I knew nothing about 401ks when I was in your shoes, but that's something you'll want to know because that's basically free money. What are your benefits? Are they covering malpractice? Is that something you have to pay yourself? That could be quite expensive. If you leave that job, are they covering what's called the tail coverage, meaning you leave? Are they still going to be paying that malpractice to cover you for things that you did, say, 3-4 years ago? Again, that can be expensive if it's not something that's covered. And then you probably really want to know, is this job eligible for any kind of loan repayment, whether that's, the company themselves giving extra money payments towards your loans or being eligible for public service loan forgiveness. That's a really big factor to consider. You probably want to know their call. If I'm going to be director of a sleep lab, am I on call every night? Which I am on call every night in my position. But do I get called? No, I very rarely get called. I think I've been called a handful of times this year, but I keep my phone around in case I get a message. Are you going to be doing inpatient consults? Is that something that's done at your hospital? Is it something you want to do or set up? We don't have that. We have pulmonologists in our practice that do consultations, so we're not doing any inpatient work. Is there a medical directorship? Are you going to be in charge of your own lab? You should be compensated for that if that's something that you're going to be doing. If you're taking consults or you're taking call, you probably need to negotiate some kind of compensation for that as well. And then again, the APP supervision, are you going to be asked to sign off on APPs? Are you going to be asked to be a supervisor? That is something too that you need to know because you need to be able to trust your APPs and give them appropriate supervision, be able to monitor, what they're doing. And also, if you are supervising, again, discussing, is there a compensation for that? So the compensation models that are out there, this might not be all of them, but there's straight salary. So they give you an amount, they pay that to you every year. It doesn't matter how many patients you see, unless there's something in your salary that says you need to see X number of patients. The Eat What You Kill, again, that's like kind of the private practice, right? Like you're seeing these patients, you're going to get paid what you make minus what your expenses are. There's some RVU based models out there. So that would be, you need to make this much productivity each year, meaning there's an RVU floor. You need to meet this floor each year. You need to get to that point in terms of your RVUs. If you don't meet an RVU floor, likely they would say, we're going to subtract that from your salary the next year. Some plans have an RVU bonus, meaning if you meet your floor, if you go above that a certain amount, you'll get paid for each additional RVU a certain amount. So you need to know those things. How are you going to be paid? Some other things that you could be paid for, you can get quality bonus if you meet certain parameters. Again, medical directorship, that should have some additional type of compensation typically. And then again, your 401k matches, know how much is being offered there. So again, not something I ever thought about when I was a fellow. I didn't even know what these numbers were probably as a fellow, but each study you read has a certain RVU. So that's the, the relative value unit. Looking here on these comparison charts, it changes year to year exactly what you get for each study, but you want to look at the 26 column. It shows you how many RVUs are per each study. Just something to pay attention to, again, depending on how you're going to be compensated. That's the same for clinic. Each type of clinic visit has a different value unit associated with that. So certainly your lower complexity visits are lower RVUs, higher as it goes up in complexity, and then new patients being higher RVUs. Negotiating your contract. Be sure you just ask a lot of questions. Don't feel afraid to ask questions. Don't be afraid to push back on what's being said to you. Know what your worth is, what you think you deserve, and try and stick up for yourself, because no one else is going to. You need to do that for yourself. Probably helpful to hire an attorney, even though that is an upfront expense to you. It probably will help you in the long run in terms of negotiating and reading through your contract, making sure everything looks above board, nothing is trying to be weaseled in there. And attorneys are also helpful at figuring out compensation. So if an attorney is somebody who is specialized in contracts, especially physicians, they're going to know baseline what compensation to expect. They will have that MGMA data. They should know that. Things to consider within your practice as well. These are big ones. Who's in charge? Am I in charge of my schedule, my template? Is someone else in charge of that for me? Who's dictating this? So things like number of patients per day. You're probably used to seeing patients on a certain schedule in fellowship. Are you going to get that time in your practice as an attending? Are you going to get the amount of time that you want to see patients? When I was doing neurology, I had an hour for every new patient. It's probably not something that one could have in a private practice, just because it wouldn't allow you to see enough patients to make enough money. But that's something you need to just pay attention to, is how much time am I being given to see patients, and is it something I think I could work with? What are you being asked to see in between new and return patients? If you're inheriting a practice or you're taking over for somebody that's retiring, you're probably going to see a lot of return visits you're taking over somebody else's management, even though they're new to you, versus starting with totally new patients to the practice. Again, we already talked about time. We already kind of talked on telehealth, if that's something that you want to do or not. Is that telehealth going to be built into your schedule in a block? That probably is more helpful. I don't know what you guys are doing for telehealth now, but it's probably better in terms of workflow to have a set telehealth block versus pushing patients in between telehealth in between in-person patients. Although I tend to just work them in if they want to be seen over telehealth. You want to know how much time do I get off, because that kind of goes into your compensation too, right? Time off that's paid, that's a benefit to you. What does it look like if I need to take a maternity leave, for example? That's a big chunk of time. So if one job is offering, say, 12 weeks paid maternity leave, and another one doesn't give you any, that's a big thing to consider if you're going to be starting a family. Time off for reading from clinic. Do you get time set aside for these studies that you need to read? For every patient, there's the study that needs read. So do you get time for that in your schedule? And then I have it in big capital letters, support staff. Who's helping you do your job? So either, do you have your own support staff? Do you have somebody that's assigned to you? Currently I do. I have my own nurse, and that's Clutch. She helps me every day, all day. Versus are you sharing support staff with others? Because that, again, is a big help to you in your clinic. So in terms of support staff, probably want to know who's my office manager, who's in charge of this practice, how is it running? Who's scheduling the patients? How are they, putting patients on my schedule? How do they decide where to put people? Front desk, or is there somebody answering phones all the time? Are patients leaving messages? How is this taking place? And then, how do those messages get to you? Do they get sent directly? Do they go to your nurse, or do they get triaged? Because I think we all know the patient portal and the inbox can get really full really quick. So having somebody, if it's available to you, to triage those things is really helpful. Also things like sending orders, rooming your patients, obviously. And then on the sleep side of it, your techs. So you have your overnight techs, obviously running studies. Is there a day tech who's scoring, somebody there in the daytime? Is there anybody that helps patients if they're really struggling, say with a mask fit, or having them come in, helping them with their mask, just some things that you may not be able to do in a clinic time, in a clinic visit. And then also just kind of in between clinic visits, things like pressure changes, what's the workflow for that? So for example, a patient calls in and says, I can't tolerate this setting. My nurse, for example, knows 100%, pull a download, look at that download, send it to me. So I have it to review for that phone call. And then again, is there anybody to help with intolerance if that's something that you can have someone in the office help patients with mask fit and just showing them how to use their machine or put on the mask can be really helpful. I think, as we all know, DME companies are not the most reliable in terms of helping people fit a mask or pick a mask. So it's really helpful if you have somebody in your practice that can help with that. I made a slide about public service loan forgiveness because for me that was a big deal. If you're not already aware of this, make yourself aware of it, because I'm assuming the majority of fellows are going to have loans. You have to work for a qualifying employer, which if you've been in a residency and you've been in a fellowship, more often than not, that's going to qualify. Those are years already under your belt. You have to have 10 years in order to qualify for that forgiveness of your loans. So for-profit employers and private practice is going to be excluded from that. So again, something to consider when you're looking for a job is, okay, if this isn't a benefit to me, am I making enough, say, on top of that to pay my loans off in a reasonable amount of time? If you're not doing the paperwork already, do the paperwork, have it all signed. It's much easier to do it now than it is to go back in time and try and get those papers signed for previous years. So do it now before you leave fellowship. Get that done. My kind of 2 cents, again, this is just my own personal opinion. So when I worked in academics, a benefit to me was I had more time with my patients. I had fewer patients. I could spend more time with them talking about various issues or problems. You do wear more hats in terms of the teaching, the education, doing your academic work. In tertiary care, as you are at U of M, you get a lot of second opinions. Do I get many second opinions in my community practice? Not really. I mean, unless people want to just change who they're seeing, but not necessarily second opinions. I also was seeing at U of M a lot of difficult cases. So, I mean, you guys are seeing a really wide variety of patients, people with really severe medical problems, lots of comorbidities. Patients that have kind of clinical conundrums that are hard to figure out. Really not as much in community practice. So I do feel like, I see more patients, probably in less time, but a lot of my patients aren't as complicated. I do work as a medical director, but nearly everything I do day to day is clinical. This is a little out of order, but I think in terms of practice management, again, that's going to vary as to where you're employed. So, if you're in academics or if you're in an employed practice, this may not be something as much that's on your radar, but, things that you need to pay attention to are new visit wait times. I mean, those can get pushed out really far. Are you being able to move patients through your practice? Are you having a lot of no-shows? How can we improve the no-show rate? Because if you're getting no-shows, that's a space on your schedule where you're not seeing a patient that could be seen. Are there any restrictions on, like completing your notes, things like that? That's just a day-to-day thing that may affect you. Press gaming, probably the bane of all of our existence, patient reviews. So some employers are going to use that and say maybe you get a bonus if you have really good Press Ganey scores. And then again, your RVUs, that again, something to really pay attention to as to a job, what they want you to do. I think we talked about kind of our EPPs previously, how you can set that up, either an independent practice where they're seeing their own patients, they're doing their own billing, they have their own panel. kind of functioning somewhat independently with oversight as needed versus running a joint clinic, which when we hired our nurse practitioner earlier in the year, we did a lot of joint visits. So kind of co-visits, which you get to share those RVUs. You get to add that to your tally. You get to make sure you have oversight and increased time with your APP. And then again, just more face-to-face time with them. Things to consider if you're hiring an APP. Are they a new grad? Have they been practicing already in this environment? I mean, that's going to play a big role. If I had Viviani or Denise, I know I wouldn't need to train them, right? So if you're hiring a new grad who say ours came from oncology, totally different world. So you need to make sure that you're really willing to do the training and put in the work. What's their schedule going to look like? Are they going to see new patients? Are they going to only see return patients? It has to be somewhat discussed as to your comfort level and their comfort level. How are you going to train them? How much time are you going to put into training them, right? So time that's training them to work with you is time that they're not necessarily seeing their own patients, but it's helpful for you moving forward to have the best trained APPs that you can. Are they going to use a template? Are they going to have their own templates? Are they doing it in person, telemedicine? Again, all these things are things that need to be sorted out that you may not be thinking about at all at this point. And then things like prior authorizations, who's doing those? Is that your staff? Is that the APP? And then are they going to be managing things like advanced therapies like ASV or bypass T? Sleep lab management, again, if you're going to be opening your private practice or you're going to be involved as a medical director, kind of just need to know the ins and outs of how the sleep lab runs. So you can have a single site, you can have multiple sites. Again, we have like 7 different sites in ProMedica, which is a lot. We have one director overseeing everything, one lab manager, and then our techs at the individual sites running things night to night. We have a director who's in charge of the entire sleep lab management, and then we're all individual directors of our lab, so we do get quite a bit of oversight as to what's going on. If you are a medical director and your lab's accredited by the ASM, there are things that you need to meet to do that. I don't need to read this, but you do need to complete a fellowship or be available to do so. And then you need to meet a certain amount of CMEs each cycle to stay as the medical director. You need to meet certain responsibilities if you're a medical director, and that's a minimum of 8 hours per month as per the ASM accreditation. You do things like review all your referrals. Any referral that comes in that's not from a sleep doctor, you got to review that, make sure it's the right study, you got to protocol it. Got to make sure you're having follow-up and consultations with a certain fraction of those patients, that correct diagnoses are being given, that there's some plan in place to respond to medical emergencies. You're doing quality assurance reviews regularly. You have to meet with your directors, teleconference or in person. We do teleconference. Making sure you're educating your techs, that you're overseeing protocols, the equipment, making sure everything's running as it should, and that your staff's trained in HIPAA and ethics. So there is quite a bit there. Again, typically you're going to have a lab manager as part of your sleep center. Those are usually people that are really experienced, that have worked as techs for a long time and are really, really helpful. Things like managing quality assurance data, scheduling, and then remediating if there's techs that are struggling or having some difficulty with scoring. Those stars on that map are just places that we've had sleep centers. And then think about your future in any of these practices. What's the outlook? Where are you practicing? Are you in a big urban center where there's lots of sleep doctors around? Are you rural where you're the only one? How are you going to get those patients? Where are they coming from? If you have demand that's somewhat low, can you pivot to doing some telemedicine to get some more referrals to support your practice? And then are you going to be able to hire techs? That is hard to find techs to fill your sleep lab at times. So We do rely on some travelers. That's more of an expense. We need techs to run the beds. So that's an important factor in running a practice. So really you need to think about, what do I like? What do I want to do? What makes me happy? What fills my bucket? What empties my bucket? What drains me? And try to think about those things as you're choosing a job. Recognize what your weaknesses are and how the practice or where you're going can support you to kind of help you in those ways. And then certainly you want to, wherever you go, have a culture of safety where people feel comfortable coming to you to have the best practice you can. Does anyone have any questions?
That was awesome, Abby. Thank you so much.
Thanks for inviting me.
Yeah, of course. Open it up for questions. Ron Chervin, go ahead.
Well, thank you very much. That was, it's always insightful to have someone who has been here a while and then can, speak to our blind sides about what it's like in the real world. So thank you for doing that. And well, I guess one of my questions is, in your practice now, are patients referred to the practice and then you happen to be there on that day, so you get them, or you have availability, so you get them, or
You mean
Yeah.
in terms of sleep and pulmonary?
in terms of sleep? And it was my real question is, or are people saying, I'm referring Miss Smith and I want her to see Dr. Dunn?
I mean both. So it's a little bit confusing because the way our practice started was as a pulmonary practice with 2 or 3 practitioners who also saw sleep medicine. So many of the referring physicians in the area are used to just referring to pulmonary and putting a diagnosis of whatever, OSA or whatnot, on the referral. So the way that it works is our schedulers and our practice, manager get the referrals, and then they're kind of triaged as to who then calls to schedule that referral. So if it says, pulmonary, but it says OSA, we're going to check the chart, make sure there's not another pulmonary concern, but then that would be triaged to say a sleep provider. If there's a pulmonary and sleep concern, they may be offered 2 appointments with 2 different providers, or they might see somebody who's pulmonary and sleep. Some referrals, yes, have my name on them. They say my name, Dr. Dunn. But if that patient calls to schedule and say I'm booking out 3 months and they want to see somebody else, I mean, they will just end up on somebody else's schedule. Our nurse practitioner in our group does not see new patients, so they don't end up on her schedule just because I find that to be difficult. I want to see those patients first and make sure nothing else is, a problem. And then when they're all kind of squared away and doing well, go off to the nurse practitioner. Just because with the volume of referrals, it's really hard for us to, although I like seeing really easy, uncomplicated patients who just need a PAP supply, it's probably not the best resource use of my time. So I do tend to transition those to the nurse practitioner, but there are people in our office that are looking at the referrals and triaging them.
Thank you.
Thanks, Abby.
Mhm.
Brad, go ahead.
Yeah, I was just wondering, like, how did you learn how to be like a director? And I guess at what point did you feel comfortable taking that role?
Oh, okay. Yeah, I didn't learn. I just started doing it. So I think like everything, sometimes you just have to take that jump and do it. I didn't learn how to do it until I just started doing it, basically. Which I think lucky for me, there were other people at the practice who already were well versed in doing this. Dr. Williams was a fellow at U of M a few years before me. We went to high school together. We didn't know each other, but she's been a help to me, just learning how to do all of that, because it's not something that you really know how to do until you do it. And then the sleep lab, your director, your manager should be a resource to you if you're joining a practice where this has been established. But if you are starting your own practice, you probably will need to use those relationships with people from U of M or whoever has been mentoring you in sleep medicine to help you figure that out, because it's not intuitive.
Thank you.
Great question. Thanks. Other questions from our fellows? Okay. Well, while people are thinking of their additional questions, I had a couple of questions. The
Sure.
first one is, you mentioned some things to bring up in negotiation. Like, what do you think is a reasonable duration of time to engage in contract negotiation?
Oh gosh, I guess it depends how long you have available. So just depending on how hard you want to go with it. So I just did my like renegotiation for my contract, and I worked on it for about 5 months. So I mean, it was a long time. And then even then, my date for my renewal came up and we didn't have it. So I mean, if you really want something, just keep going for it. I mean, if both parties are willing to keep negotiating, you certainly can, but I think everything is negotiable, as they say, right?
Yeah, that's helpful. And that's a longer time period than I thought you were going to say. So that's just instructive as people are
Yeah,
looking at start dates and things like that.
right.
Yeah.
Yeah. Yeah. But I mean, I think if things aren't going anywhere, don't be afraid to, if you have something else out there, don't be afraid to use that to your advantage and say, well, okay, if you're not going to give me what I want, I can go XYZ place and, maybe they're willing to give me what I want. And I think you can use that to your advantage.
And do you use the attorney to help you with that negotiation process so
Yes.
that you're
Yeah.
not directly asking
Yes.
the employer?
Yeah. So my initial contract, I did use an attorney who did look over all the documents, although she would just tell me what to say, for that contract. And then this most recent contract, I was in Hawaii. I went to the Mayo Clinic Hawaii conference, and she just called directly to their attorney and discussed things. So, I mean, obviously, you're going to have to pay the attorney if they're doing that. So just be forewarned.
Yeah, that's helpful.
Yeah.
Does anyone else have another question? If not, I have one more. You had mentioned in terms of the different salary or payment models and that if you're in the type where it's your revenue minus your expenses, do you have any suggestions on what our fellows should ask about in terms of how overhead expenses are calculated, or what type of things they
Yeah.
should expect to
I
be
mean,
part of overhead?
I think that depends on the practice, right? So, like, I don't know what my overhead is here just because that is not something that we're privy to. I mean, I guess if I wanted to get the info, I could. We do have meetings where we look at our revenue, how much we're generating, blah, blah, blah. But really, I think what you want to look at is what are they paying kind of per RVU? Like that's a way to compare, say, two job offers. So, if you're looking at one and they say, okay, we want you to generate 4,800 RVUs a year, whatever, and then this is going to be your base salary. Trying to figure out what that RVU kind of conversion factor is that they're going to give you. And every practice, I mean, they should know what that number is. They should know what are we paying you per RVU, and then you should use that number as your comparison from job to job.
Great, thank you. Other questions for Dr. Dunn? Oh,
I have another question if
Please.
no one else does. I guess it's like more of a selfish question, so sorry everyone. But I'm pediatric pulmonary, and I'm looking for a combined hybrid job.
Yeah.
I guess like, do you have any advice for me? Like, I guess, or like just from your perspective, like in the job market, and I guess yeah.
Yeah, I guess it depends on how you want to structure your practice, right? Like, so do you want to work somewhere where, say, is there already a sleep practice or is there already a peds pulmonary practice? Because generally those two things are not together in most practices. So we do in our office, Dr. Rulong, he was at U of M as attending for a while. He does sleep medicine. He sees patients in our clinic, both adults and peds, for sleep disorders, but he also does peds pulmonary. It's just that peds pulmonary work takes place at another clinic within ProMedica. So are you going to be dividing your time amongst two clinics? Are you going to have some way to combine your practice? I mean, I think you just need to figure out the logistics of how that's going to look. I think that will be the issue. And that's same with me when I did neurology and I did sleep. I worked in U of M's neurology clinic. I worked in the sleep clinic. Some of my patients had both problems, right? And maybe I saw them in both clinics, maybe I didn't, but it became a little bit complicated. So I think you just have to work that out with whoever your employer is as to what it will actually look like and how will that be divided in terms of where people get scheduled if you do have, if there are two practices already in place.
No, yeah, that's a great advice. Thank you.
Yeah, thanks, Abby. Other questions? No, and I do
I
see
just had
you. Oh,
one,
please go ahead, Abby.
I don't know if this is rumor or how true this is. I've heard about this. Is in terms of like patient calls outside of clinic time, when I guess a lot of places they're seeing that access to the portal has been great when you have small questions, follow-up questions, but some of these questions end up turning into entire visits where you're managing patients' care and changing meds, ordering new ones or whatnot. And certain institutions apparently are starting to charge for that because that is, you are doing extra work. You're doing, in addition to clinic time, you're sometimes reevaluating. Is that something you're seeing out there that's more common, or is that okay?
Yeah. So I think exactly as you said, if it's not a follow-up question, or if it's not a very quick question, if it's something new, I mean, I think you have two options. So our facility is starting billing for those type of visits, I guess you could say, like an e-visit, but the guidance, like for our facility, is okay. So patient sends you a message and they say, I have new problem X. This is what's going on. What do I do? You have two options. You could either say, okay, should we make this an e-visit? Do you want to kind of engage further, or should we just make this an office appointment if it's truly going to take that much time? Because the patient really needs to be aware, right, that you could be billing this as a visit going forward. So I think there needs to be some communication, probably not maybe from you, but from your office, and say, okay, we got your message. Do you want to start, do you want to do this on online communication, or do you just want to come in? Because either way, if you're spending more than 5 minutes and you can bill for that, there will be a bill. It's just, do you know, is it going to be paid? Is it going to go to the insurance? Does the patient have to pay for it themselves? And it kind of gets somewhat nebulous. But yeah, our facility is starting to implement that. We haven't started doing it yet, but that's the plan.
Okay, thank you.
I had one more question, Abby. You mentioned about, inquiring about the time available to read sleep studies. Is this after hours? Do you have any sense of like framing realistic expectations in terms of what our fellows should consider as a red flag versus, oh, that's actually kind of par for the course when you're looking for jobs?
I think it depends on what the RVU goal is, what the compensation is, right? So I think for me, for what we're doing here, we get time to read our studies. We're in clinic 3 full days doing clinic, and then our other time is our time to do admin, do sleep studies. But I think if there's a really high RVU threshold and they're expecting you to be in clinic, right, say like 4 days a week, and you need to be there 9 to 5, your sleep studies are going to fall to your after hours. So I don't think it's unreasonable to make a request for what you want to do. I think if you're not going to be given time to do the studies in clinic, that you just make sure you're being compensated appropriately for that. I mean, you're seeing patients all day, every day, and then you're reading sleep studies. That's a lot of work. That's a lot of time. You get tired. And I think, if that's what you want to do, which certainly, we have the ability in our practice to do extra hours, do extra reading, and get compensated for that, which some of us in our practice do 0. Some do a small number. Some do a really extremely high number of hours per month. And that's all just based on what we each want to do individually. But I don't think it's unreasonable to ask for what you want, certainly, to have protected time to do that.
Great. Thank you so much. I don't see any other hands up. I do see that you shared your contact info, so thanks for sharing that. I'm sure people will be reaching out if they have different
Yeah, feel
questions
free.
as the job search
Mhm,
process
yeah.
continues.
Yeah,
Awesome.
I'm always welcome. Anybody contact me if you have questions or, things you want to know. I'm happy to answer questions.
Great. Well, thank you so much again. This was fantastic and great to see you, and congrats on all your leadership roles and
Thank
everything that you're
you.
doing.
Thanks. It came from you guys. You trained me. I did a good job.
Go Blue.
Yeah,
Yes.
that's great. All right.
All right.
Thank you.
Thanks, Abby.
All
All
right.
right, thank you.
Bye-bye.
Bye-bye.